And I think it would be great to get started. Hi, everyone. Thank you so much for joining us this morning. I am so happy and privileged to introduce Lorraine Leist this morning. And we strive for interprofessional grand rounds here at Palliative Medicine. So I am so thrilled that she agreed to my invitation to join us this morning and speak on her work, which I think is very important. So by way of a quick introduction, because Dr. Leist will introduce herself in a little bit more depth, Reverend Dr. Lorraine Leist is an advanced board certified palliative care chaplain at Providence Swedish Medical Center in Seattle, Washington. And she has worked in healthcare chaplaincy for 14 years in Colorado and Washington State, specializing in palliative care for 7 years. Lorraine received a BA from Wellesley College and a Master of Divinity and Doctor of Ministry degrees from the Iliff School of Theology. Lorraine worked as an affiliate faculty for the California State University Shiley Institute for Palliative Care and is passionate about spiritual care for people living with serious illness. So without further ado, I'm going to turn it over to Dr. Leist and have her share her presentation with us.
Great. Thank you, Dr. Harano, for having me, and thanks everybody for being here today. I'm excited to share this presentation with you, and we'll just jump into it. So to begin, I'm just going to do a little bit of additional introduction to this presentation. The introduction given in my bio is perfect. It's right on. And what I want to do is say that part of this presentation is going to be an introduction to the doctoral research that I did earlier this year. And the research question that I addressed was, how do people who are nearing the end of their lives make meaning out of and cope with unfinished life tasks as they prepare for a good death? And this topic was really born out of my passion for seeing our patients in palliative care struggle with these issues, and I just wanted to understand the issue a little bit more. So what we're going to do in our time together is I'm going to introduce you to a case study. I'm going to lead you through a life completion exercise. I'm going to show you a little bit of information about my research and the findings, and then we'll have some relevance to the clinical context and discussion. So my hope is to really be able to raise some rich discussion at the end of the presentation. I'm wondering just if you guys can think for a minute about whether or not unfinished business is relevant to your clinical practice. Just sort of center yourself a little bit around this concept, and if you have a pen and paper handy, it might be helpful for this life completion exercise. If not, you can kind of imagine it as well. But what I want to start with is a case study. This is entirely fictional. It's not actually grounded in one particular person, but it is based on my experience and should hopefully resonate with some of you. Some of these themes should resonate with some of you. This patient is called Maggie. She's a white woman, aged 49. She had stage 4 metastatic breast cancer. She'd been in and out of the hospital with complications related to her treatment several times over the course of a year. And our team was consulted each time for either goals of care or support. Initially, we began to build rapport with her in our initial consultation with the medical provider, the oncology social worker, and myself as the spiritual care provider. This patient, Maggie, was hopeful about treatment. She was on her 3rd line of treatment options. She was still full code, and she wanted full treatment. And during the initial consultation, we learned that she's a widow. She's a single mother to 3 children, ages 22, 20, and 16. Her adult children are her legal next of kin, but she is supported by a significant other of 3 years. They do not live together. She has a brother and a sister who live out of state, and she's been estranged from her brother for over 10 years. And we also learned that she owns a business, a hair salon that she built from the ground up, and she considers herself spiritual, but not religious. So through subsequent follow-up visits over the course of the year, we learned that she has the following concerns. She does not want to be a burden to her children. She wants to ensure that her youngest, who's 16 and still in high school, is cared for through high school and into adulthood. She would prefer that her significant other make medical decisions for her, but she has no legal paperwork in place for this. She wants to sell her business so that she can provide for her children after she's gone. She does not have a legal will. She would like to try to find a way to reconcile with her brother. However, she's unsure if she can do this due to forgiveness issues from childhood experiences. And she has a dog to whom she's very attached, and she wants to find someone who will be able to take care of him after she dies. So these are her completion tasks. She struggles with completing these tasks over the course of the year due to fatigue, symptoms from her treatment, and the overwhelm of professional and parenting responsibilities. Each time she's hospitalized, she's weaker. She returns for the last time with intractable bone pain and mild confusion due to brain metastases, and she has some mild respiratory distress. She remains awake in oriented ×3, and by this point, her completion tasks have become unfinished life tasks. She's concerned about not having completed them despite her declining physical status. She wants treatment, and she's still full code, and she still wants aggressive medical measures. So the palliative care team has introduced the idea of the supportive hospice, and she says she's not ready for this yet. She mentions that she needs to get better and go home to tie up some loose ends. So the question I have and want us to consider as we go along is several questions. What do we do with all of this? How can we help Maggie to have a good death in light of her unfinished life tasks? And what might a good death actually mean for her, given everything she's experiencing? So for my research, I conducted a series of workshops in the community held in Washington and Colorado about finding meaning and hope towards the end of life, and about an exploration of what a good death means. So to set the stage, I want to lead you into a deeper understanding of what it means to have unfinished life tasks near the end of life. And we may be familiar with this idea from our work and maybe from our personal life, but I think it's important sometimes just to drop into our, our heart center and our body and try to see what this feels like or what it may feel like to our patients. And this is an invitation only. You can feel free to opt out if this doesn't feel comfortable. I have a deck of cards called Go Wish, and they have wishes on them, like to be free from pain, to have someone who will listen to me, to have my financial affairs in order, and etc. And what you'll see on your screen is a list of all of these cards. So I've written them down, and what I want you to do is to choose 3 of these that look important to you as you consider the end of your own life. And I'm just going to give you, just a few seconds here to have a look at that list. And if you have pen and paper, write them down. If not, just stick them in your mind and hang on to them for a minute. Okay, hopefully that was enough time just to glance through the list and pick 3. And now what I want us to do is think about limitations. So you've got your 3 things that are important to you. These are not the only kinds of completion tasks that exist as you compare maybe to the case study, but they're just an example of some that might be there. But the reality is that limitations sometimes come up as we near the end of our lives, which prevent us from actually being able to complete our wishes as we would like. So what I'd like you to do is at random, take one of those wishes away. So now you're left with only 2 of the 3 things that you want towards the end of your life. And if it were easier to do, and if we had more time, I'd spend some time asking you how you feel about it. What I want you to do instead is just take 30 seconds and write down a few words for yourself on your pen and paper, or just think for a moment. How do you feel about this? Does this feel painful? Do you have anger or frustration or despair? What are your emotions that you feel knowing that there are limitations? Okay, I only gave you a minute for that, but that's the idea. Now what I want us to do is something called re-goaling, which is based on Feldman's 2015 work around this topic. And it's really about finding hope and reimagining the end of your life in light of the limitations you are facing. So now that you've had a chance to sort of express yourself, knowing that you have limitations, is there a way to reimagine the end of your life in light of these limitations and find hope in the process? So just take another couple of seconds here to think about, how would you reimagine the end of your life without that one thing and still find hope in the process? Okay, so that just gives you a feel for what it means to have unfinished business and make it a little bit personal. And I appreciate you participating, willing to participate in that experience. My hope is that it just gives you a feel for what limitations are like towards the end of life. Now what I want to do is explain a little bit about my doctoral research and the relevance of this to our clinical context. So I began with the premise that the diagnosis of a serious illness or aging can invite reflections on mortality. And such reflections often involve considerations about life completion and what makes death good. But there's actually very little research focused on the realization that completion tasks might remain unfinished and how this might influence one's idea of a good death. And so this project was designed to address some of that gap in the literature. And I want to start with a few key concepts. The first is, what is life completion? So Karen Steinhauser and her colleagues identified the idea of life completion in a study about what makes for a good death in 2000. And she later defined it as a process of looking back to assess one's life and looking forward to prepare oneself and one's loved ones for the remainder of life. So what are completion tasks? Some years ago, Dr. Ira Byock worked with Eric Castle's ideas about suffering and Erik Erikson's theory on growth and development to create a set of developmental landmarks and task works around the end of life. And he proposed that this is a season where considering final tasks can be a season of growth and development in one's life. And he defined some of these task works in a couple of ways. The first one is consideration of worldly affairs. So here we think financial affairs, legal affairs, that sort of thing. A sense of completion in relationship with community. This could be related to employment, like retirement. It could be related to leadership positions in the community, whether that's congregational or organizational. A sense of completion in relationships with family and friends. And here we're talking about leave taking, reconciliation, forgiveness, acceptance, gratitude, these kinds of things. Acceptance of the finality of life, or recognizing that life is not as limitless as we so often hope to believe. And then the idea of simply letting go. So then what are unfinished life tasks? There's something potentially hopeful about completion tasks and life completion. So Byock describes this as having the potential for growth towards the end of life, and Steinhauser and her colleagues say that life completion provides a sense of meaningfulness. However, some scholars believe that the presence of unfinished business at the end of life can lead to existential distress, and that may be familiar with some of you from your professional practice. And I came to see that the contemplation about unfinished life tasks does indeed cause distress, And that unfinished life tasks evolve for people as they experience changes, whether they're physical, spiritual, or emotional, that are related to illness, debility, and aging. So what is a good death? That's always a question in our work. And I think I want to present a little bit of what the literature says. In a landmark study in 2000, Steinhauser and her colleagues identified 6 components of a good death. And you may be familiar with this study already. Pain and symptom management, clear decision-making, contributing to others, affirmation of the whole person, preparation for dying, and life completion. And then in a more recent study in 2016, Meyer and colleagues conclude that a good death is one that is free from physical and psychological pain, that cultural and spiritual beliefs are honored, and that the dying person's wishes and their loved ones are respected. But still more simply put, Suntai and colleagues in 2022 write that a good death is one where patients' preferences and wishes are fully respected. But what's important to remember is that perspective matters. Perspective matters in the dying experience in terms of what makes good. It's unique to the ill, to the dying, and to the loved ones and care providers. And really much of the literature prior to about 5 years ago is very general, and more recent research has begun to address the differences in this concept by condition, culture, race, and religion. In the last 5 years, there's more conversation about what makes death good for separate populations. For example, some aspects of a good death are more important to Black, Indigenous, people of color, LGBTQIA2+, and those who are unsheltered, or even people with dementia or other cognitive or psychological differences. And an example of this is that in some, as compared with the earlier studies, we now know and are more aware of the racial and ethnic disparities in end-of-life care, such as access issues, understandings of care, and sometimes even provider discrimination that may prevent people of color from disproportionately achieving the death experience that they're hoping for. So in terms of my research, I started with an interest in palliative care, as I mentioned, in terms of understanding people's experience with unfinished business and how this impacts how they prepare for a good death. And my original research project, I was set to interview 2 to 3 people from a palliative care clinic in an outpatient setting, and also their loved ones about life completion, unfinished life tasks, and a good death. And after 6 months of unsuccessful recruiting and then running into an administrative snag in my hospital system, I stopped and switched gears. What I ended up doing is moving upstream and moving to people who are relatively well. So I still addressed the same research question, but I did 14 workshops over a 5-week period, and I worked with 267 people, and I invited survey responses after each workshop, and I ended up with an 80% survey response. The workshops themselves, one was called Moments of Peace, Finding Meaning and Hope Toward the End of Life, was a 3-hour workshop. And the second, Dying Well, an Open Conversation About a Good Death, was a 90-minute workshop. So to answer the research question, I considered who is contemplating their mortality? How do people cope with unfinished life tasks? How do people make meaning out of them? And what does it mean to make death good? And here's what I came up with. The demographics show that the majority of the participants in my workshops were older white women, and they were overrepresented in the senior living communities I worked in, the congregations I worked in, and even the hospice agencies I worked in. The racial categories were like national averages in both cases, but it raises questions about my research that relate to this distribution. So for example, I used a convenient sampling method And I reached out to continuing care retirement communities and congregations from my immediate network, and these were not racially diverse. And I also was curious as to why this resonated more with women than men, but I don't actually have survey data to answer that question. So how do people cope with unfinished life tasks? They did it through finding hope and through spiritual practices. I led people in a re-goaling exercise, much like the one that we did just a few minutes ago. And 94% of people said that they found that exercise helpful. So for example, one woman wants to walk to her granddaughter's high school and college graduations. That's really important to her. And she expressed that at age 88 and 92, it could be that there are limitations in her ability to ambulate. So she found the re-goaling exercise helpful to modify her expectations that perhaps she could use a walker or a motorized vehicle if she was unable to walk, but she could still maintain her independence. So where do people find hope? They found hope in regular intentional practices, faith, family, and loved ones, reflecting on the existence after death, letting go, and nature. The spiritual practices that we engaged during the workshop were embodied practice, use of a stone exercise, lament or expressing anger and grief, and presence like breathing techniques, mindfulness exercises, and guided meditation. All right, so how did people make meaning out of unfinished life tasks? Interestingly, it was through storytelling and discussion. Participants overwhelmingly said that the best part of the workshops was actually talking to each other or sharing their stories. They also gave thoughtful answers to survey questions that were open-ended. That was something that people found very helpful. So what does that mean to make death good? As I mentioned earlier, a good death varies by person, social location, and medical condition. This was reflected in the open-ended questions that people answered. And examples are that one woman writes, she wants to be relatively pain-free and make sure her wishes are followed. And she sort of goes on to say some more things. But another woman shared in a workshop that in her faith tradition, there's a redemptive component to suffering at the end of life. So pain management is actually discouraged. So the limitations to this study, the study cannot be generalized. The organizations were collected through convenient sampling, and the participants self-selected into the workshops. And then not all people completed their survey. So the conclusions I make really only refer to the individuals who attended the workshop and completed the surveys. And because I worked with mostly older white women, I don't have a good sense of what BIPOC or people from other marginalized communities may feel about these issues. All right, so enough about my research. Why is this relevant in our clinical practice? I think it raises questions about the prevalence of unfinished life tasks in our practice and the need for addressing it and supporting people around these issues. And then it also brings up a curiosity for me about what is helpful from our various disciplines within palliative care for people. So some examples of unfinished life tasks besides the case study are that perhaps a patient can no longer receive treatment for cancer, but is estranged from her son, and she wants to attempt to resolve the relationship before accepting the support of hospice care. Another one might be a patient whose condition is declining in the ICU on high-flow nasal cannula, and they've yet to complete their legal affairs. In this case, his notary is scheduled to come the following day, but his O2 sats are dropping. But he won't remove the oxygen support, nor will his family move toward comfort care until the paperwork is completed. And the final one is a patient who has end-stage renal disease, wishes to distribute their belongings to their loved ones before they stop dialysis. So what do we do in our clinical practice? I think the first thing we need to do is assess for the existence of unfinished life tasks, and that involves encouraging storytelling, really listening to patients' narratives, and kind of carefully attending to the kind of distress that they may have as they're considering completing their life. If appropriate, go ahead and reflect those things back so that people can name them for themselves. Notice the patient's response to limitations. Is it existential? Is it spiritual? What kind of distress is present? And again, in the assessment, we want to allow for the expression of grief and anger and other associated emotions. Make room for the discomfort that people are feeling, and do this without moving to fix too quickly. And really engage in a discussion about finding hope a little bit down the line once people have had a chance to express themselves. And then and only then should we attempt to readdress goals of care. So how do we help people cope with their experience of serious illness? My study points to the idea that people cope through embodied practice, expressing their anger and grief, and being present. And the questions here become, who and how do we as clinicians actually help people with this? I think it's important to rely on our social work and spiritual care colleagues who may be more trained in some of these kind of listening activities, and also trained in helping with resources and this sort of thing, and also finding ways to engage spiritual practices along the way, because it's my study showed that spiritual practices were actually important and may also be important in this clinical context. And then also, again, for people who to make meaning, let's have them tell stories and discuss what's going on. Part of the discussion can include concerns about death and dying, to really openly address that. And I often split in my own work with people around that, the issue into how do you feel about the process of dying versus how do you feel about what happens after you've died. And those bring up very different kinds of discussions, and unfinished life tasks can come out in that discussion. So finding hope. Re-goaling is a coping strategy that can help, but again, not moving to it too quickly. And also all of the practices that I mentioned earlier that where people find hope, like regular intentional practices, engaging in their faith, or a lot of times with family and loved ones, that sort of thing. And then we can also just inquire with people, how do you find hope going forward? So now what I want us to do is to return to the case study. And I'm going to stop sharing my screen so that we can have a little discussion here. So again, I just want to recall a few of the details. Maggie is 49. She's a white woman with metastatic breast cancer that's spread. She's the mother of 3. One is still in high school. She's got declining health, but she still wants all aggressive measures. And her unfinished business, she doesn't want to be a burden, particularly to her children. The care of her youngest child is particularly important. She wants to make sure her significant other makes medical decisions for her. She wants to sell her business. She needs a legal will. She needs to figure out, or wants to figure out, something about reconciliation, if that even feels possible to her. And then her little dog needs a home. So I want to start by asking the question of, what do we do with all of this? As clinicians, how do we address these unfinished life tasks in the setting of kind of finally and now nearing end of life with this serious illness? And I wonder if anybody has any ideas. What are the kinds of things that you might do to address Maggie's unfinished business? Anybody have any ideas?
My name is Doug Lane. I'm a psychologist with a specialty in geriatrics. And so through that lens, I almost wonder if for her as a parent, there's some guilt that she needs to work through regarding her son, in terms of, I'm always your mom, you're always my son, no matter how old you are. And if there's some guilt that she's feeling about what happened in that relationship, if there's some responsibility she's feeling like that was my responsibility, that I haven't been more assertive in trying to heal that, and almost a need to apologize to her son as part of the reconciliation. The reason I say that is I've worked with a number of older people, and it's been striking. Older people who didn't know each other, separate cases. And in my case, because we're talking about older veterans, just because of a historical cohort, they're generally all men, but who have estranged children, and to the person, they've all commented that something along those lines, like, it's still my son, that's still my daughter, I'm still their dad, I've still got to try. And so that sense of responsibility, even though the child is an adult, is still there. That sense of superior responsibility as a parent is still there.
Oh, thanks, Doug. I really appreciate those comments. And kind of that lens of diving into guilt and what does reconciliation mean, and really exploring those emotions seems really important. Thank you for that. Anybody else have comments about, what do we do?
I'm Amy Hamblin. Excuse me, I was a caregiver. And one of the first things that comes to my mind is to have a discussion with this woman about the important people in her life and how they can be brought in as resources to delegate some of these tasks and help her think through how to meet her goals with help.
Oh, I think that's an excellent point, and helping her realize that it's not just her leaving, but that in this season of approaching end of life, they can experience all of this together and work together towards completing some of these tasks. That's wonderful. Thank you.
Right, and for them, having been through this, I think that my friends have felt that it's not a burden, it's a gift. Mm-hmm. And kind of so to change that idea of the dynamic of putting people on the spot from giving them an opportunity to help and to love you that way.
Yeah, wonderful. Thank you. Thank you for that.
Mm-hmm.
Hi, I'm Melody Kroger. I'm a chaplain fellow at the VA in Seattle. And all of these points are great. But I'm wondering about the patient's relationship with her dog. Mm-hmm. So many of our veterans have estranged relationships with family members, with neighbors. But their relationship with their pet, usually a dog, is the most whole relationship that they have. It's the way that they feel and can express unconditional love. So I'm wondering if that's an area to explore, because I can't imagine dying, but worrying about that most important relationship to me at this moment of time and what's going to happen to that dog. Thank you.
Yeah, thank you so much for that. I think that piece of it sometimes can get lost because it doesn't seem as important, and yet it can be among the most important things that someone is actually worried about. And I like the idea of calling on the resources in the community that we just discussed a moment ago to help figure out what might happen to this beloved pet. If it is that her adult children can't, are not in a position to take, then how can the whole community come together to figure out what's the appropriate next step? So just to reassure her that her pet will be cared for. Thank you for that. Any other comments about that piece of it?
Lorraine, you have two hands up. Joanne's went up first, and then we'll have Megan unmute and comment.
Okay.
Sure. Thanks so much. So I'm Joanne Roberts. I'm a retired palliative care physician and now living with my own life-limiting diagnosis. So I was really looking forward to this. So thank you for this. I know, we are given the patients we're given. So the circumstance, I think we're all familiar with. But maybe I could just throw in a thought about how we got to where we are with this patient. And recall that when I got my diagnosis, I have myelodysplastic syndrome, and I've had it for 2 years. When I got my diagnosis, the day of, I saw a palliative care social worker and began working on these life tasks that day. And pretty much that's been my full-time job for the last 2 years. And feel like, number one, I've accomplished so much in preparing for my death. And number two, I'll never be totally done by the time I leave. So when I think of the case that we're given and recall my days in practice, I have to say I would be terribly confused and would be leaning on spiritual care and social work. But this poor woman is in a difficult situation.
Thank you so much, Joanne, for being so open about your experiences, both professionally and personally. I think it brings a real personal lens to this particular idea of having unfinished business. And it sounds like that early intervention on the part of the social worker has been key to your experience. And I wonder if that's something for us to consider. How early can we actually get involved in having discussions and identifying what these tasks are and figuring out how to help somebody along the way with them? So thank you, Joanne, for that.
I've found in some of our work that not everybody can address these things directly and concretely. And so I think it's always our duty to explore and offer that and see if someone is ready. But I found many people who cannot do that, and especially when they're nearing the end and their physical suffering is so great that it's taking all of their energy, and the pain of unfinished life business is just lifelong and very deep, and they're not able to really tackle it directly, that giving them the space to explore it indirectly and somewhat more like circular and circumventional conversations can be really, really meaningful and helpful. And that's where I draw on my social worker and would draw on spiritual care if we had one on our team, because I think those team members sometimes have the expertise to recognize when a conversation that doesn't seem to necessarily directly apply to the situation we're discussing right now is actually really important, and that someone is processing those that unfinished business and those life tasks in an indirect way that's really important. So I like that you highlighted using those team members, because I do that a lot.
That's really helpful, and it draws to mind for me the importance of something I didn't mention earlier, but that's to really recognize that not every person wants to address this head on. Not every family wants their person to address this head on. So, for example, I'm familiar with the expression "thoughts are things" from some people. The idea that if you think about the end of life, then it will become, then it will happen. Or cultures where telling a person that they have serious illness and maybe nearing the end of their life is not appropriate. So I think you're right, Megan, addressing these things indirectly can be really helpful, particularly in cultural situations where addressing them directly is not only unwanted, but maybe inappropriate. I think I saw a comment in the chat. Let's see. I would like to ask the patient what she's hoping for. Oh, that's good. Yep. because she's lost so much, and figuring out how to prioritize. Yeah, that's a really good point as well. Not just focusing on what's being lost, but figuring out what's being, if not gained, then appreciated, can be helpful as well. And that avoiding the tendency to fix. One of the things I think is really, really important is to allow for the despair. Because the fact is that we're never finished. There may always be things that we want to get done in life that there just isn't time to complete. And so we need to allow for the despair and just accompany her in her pain. Just come alongside and be willing to be there without fixing too quickly.
Hi, it's Amy Hamblin again. I don't know how to raise my hand. I'm sorry. But the other thing that I think can be helpful is to provide, it's kind of like when you have an itch, you scratch it or you slap it or something just to get it to go away. And if there's something you need or something you feel you need, like unfinished business with your brother, maybe just spending the time to write a letter about how you feel. Maybe you can't make contact with him. Maybe he's not in a place to engage, but there's something concrete you can do to allow you to kind of put that need away. With a son, with a kid, maybe writing some letters for milestones. Just, little things that serve those goals, those major goals, indirectly.
Yeah, thanks for that, Amy. This brings up for me what I want to propose as a kind of best case scenario for Maggie towards the end of her life, or maybe not best case scenario, but a conclusion to her situation, which involves some of those things that you've mentioned, and in fact is missing some of them that you mentioned as well. So they're really good suggestions. Having the social worker help with resources for grief for not only her youngest child, but the whole family. And having someone get a notary in to complete that DPOA and legal paperwork if it's done. A chaplain can spend time at the bedside, allowing for the expression of grief, anger, despair, all of that, doing that accompaniment, spending the time coming alongside. And this can include existential questions about, why is this happening to me? Spending time with that question. Chaplains can do interventions like leading guided meditations and talking about fears about death and dying. I think that the provider and the team can talk with Maggie about her transition to comfort-focused care and what that might mean. And again, spend time in that discussion. In this case, Maggie could not make the decision herself by the time, she couldn't make a decision to go to change her code status, but by the time she was abtunded, her family made the decision for her, wanting her to have a peaceful passing. And this is just a kind of an important thing to remember, that family is an important part of this process as well, or loved ones in general. And in the end, Maggie died surrounded by her significant other and her children, and she appeared comfortable when she passed away. But I think the things that you mentioned, Amy, about writing a letter, for example, in the case of estrangement, sometimes writing a letter and not even sending it allows for the expression to come out. And again, things with the children, those milestone letters, those legacy letters, that ethical wills, that kind of thing can all be very important.
I really appreciate those points. I was just going to piggyback on there. Just as a psychologist, and I've worked in therapy with people at end of life a lot. And one of the things we do sometimes is to look like developmentally, like over the person's lifetime, and who have they known who's passed away in their family, and everybody has. And what were those passings like? And what are the traditions? What are the things from the past and those people that might inform her goals at this time in her own life? And the way that again, act of writing a letter or whatever it is her serving a function through her own dying, which is continuing, either setting a new tradition or continuing traditions, if they're positive or negative, depending, for her son. you know, around dying, and because how he sees his mother pass will inform his own grief, and then, you know, his life thereafter, so that her dying doesn't just bring her to an end. She lives on in a very real way with him, even though they might be estranged.
I think that's another excellent point, and helping her see that the way in which she is dying is still teaching them, is still parenting them, is another important point. Yeah, thank you. Joanne has a nice comment here in the chat. The social worker said, yes, you have a life-limiting disease, but you aren't dying today, this week, this month, and maybe not this year. Your work is to choose how you will live whatever time you have left. Oh, I agree. That is powerful advice. I like that a lot. And again, that early intervention, saying things like that, that's powerful. I don't know how much time we have. Do we still have time for more comments?
Yeah, you have about 15 minutes, Lorraine,
Okay.
so you can keep going.
So I have some, so that's the case study, and some of these may overlap with the answers we've already had, but I do have some additional questions, and I'm not going to bring them up on the screen. I'm just going to read them to you. The first one is, does it resonate with you, this idea of unfinished business or unfinished life tasks? How many of you feel like you encounter this in your work? I just want to kind of take a poll to see if this is prevalent or if this is just unique to a few of our experiences.
I see it a lot just working with older people in general, even if they're not, you know, coming to end of life, because in a larger way, it is such a normal developmental process. To reach the end of our life. Ericksonian, Erik Erikson, in his work around consolidation of ourselves and what is it meant to be me, and which includes all of this kind of these issues. So hopefully someone might have even started with that before they reached the end of life.
Yeah, and that actually brings up one of the other questions that I have later. And what's the appropriate time to begin to address this work? Is it at initial diagnosis? Is it at the end of life? Is it well into the community earlier? And then who are the people who are doing these tasks, are doing these activities with people, these interventions? That's sort of another question that I have. Is it in the clinic? Is it in organizational or faith settings? Is it with psychological care providers, that kind of thing? But anyway, I move forward a little bit there. Other people find this experience resonant? All right, well, hard to say there, but I'm going to assume that more than myself and Doug have this experience. My next question is really talking about what a good death means, and how does the potential for unfinished life tasks prevent some people from establishing clear goals in care that could help them prepare for a good death? That was sort of the thrust of my impetus for looking into this, is seeing that goals of care conversations were sometimes stunted by people not feeling able to address their completion tasks. So I just wonder if anybody has thoughts about that. Oh, there's lots of stuff going on in the chat now.
Oh yeah, I just wanted to point your attention. There's a lot of comments in the chat, Lorraine, agreeing with your first question.
Okay, great.
And you have a hand up as well.
Oh, great. I'm having trouble seeing. So whoever has their hand up, go ahead and chat.
Hi, Lorraine, can you hear me?
I can.
Okay, this is Laura Pearson, a nurse practitioner in Kalispell, Montana with Palliative Med. And to your question of should those goals of care conversations happen earlier? Oh, my word. Yes and amen. That is one of my biggest frustrations. I only work inpatient. Our team does work outpatient in a clinic as well. I personally just am in the hospital at this time, but that's one of my biggest frustrations. And I so appreciate the woman who earlier shared her personal and professional experience of having that social worker come early and how that gave her the time to think about these things. My experience has been, and I'm going to throw the oncologists under the bus, but it's not just them, but that's who I'm going to choose to focus on right now, of what I am going to maybe unfairly label as false hope that is so often presented of we can fix it, we can fix it, we can fix it. And so there's that undergirding false hope that the patient has that they're going to have more time. And therefore, I don't have to focus on fixing these other things or completing those life's tasks. And people, I think wrongly, aren't even given the opportunity to really look at it until it kind of is too late and their physical symptoms are taking so much of their energies that they really can't focus on those things anymore. So it's the problem of open, honest conversations early on that still have hope, but also a what if, and maybe we need to look at the what ifs. And if this is the case, what do you need to accomplish?
Yeah, I really appreciate that. I think it really speaks to the importance of early intervention for palliative care, and as early as possible in the diagnosis of a serious illness. And like you said, taking the risk to kind of peel back the curtain a little bit and address those what ifs. Even if you close the curtain afterwards for a little while, having those, crucial conversations, taking risks to really address these things. It's not always comfortable. It's not always easy, but particularly because it is despairing sometimes until the hope is unearthed. At least that's true in my experience. So yeah, thank you for that.
And you have a bunch of new comments in the chat too, Lorraine. So I'm going to give you a chance to take a look at some of those.
Okay. Unfinished business is an ongoing life process. So true. I see this in my work as palliative care medicine very often. I like the geriatric focus on what matters most. That's a great orienting question. That's very true. And then a quote from my 72-year-old hematologist: all cancer is terminal. Sometimes other issues intervene to end life, but if we live long enough, we will all die of cancer. We all will die of cancer. Okay, I get it. Yeah, I like that quote a lot. It's helpful to remember the terminal nature of life, which is hard to reconcile sometimes. Yeah.
And Amy has her hand up.
Okay.
Amy, did you want to go ahead?
Okay. Can you hear me now?
I accidentally
Sorry,
figured
I was
out
like,
how to raise my hand. I think too that it does a survey. I went through this with my brother, and I think it really was a service to him to have somebody say, it's, you have time ahead of you and you have things you can do. And you might start thinking about what you want to have accomplished, what what goals you'd like to meet. And I think that helped him maintain a sense of agency to the end.
Mm.
It wasn't just that he, I think there's a pivot point where somebody who's dying, can either focus on the death side or they can focus on the continued agency until death. And I think that was really helpful for him.
Yeah, Amy, I appreciate that comment as well. I think what comes to my mind when you say that is the idea that agency is so important, and also recognizing that you still have agency in adaptations to expectations, because as fatigue or treatment side effects and these kinds of things go along that make it harder to actually complete tasks, there's still agency in adapting what can be done. And I go back to that example of writing the letter to the brother from whom she's estranged, and as an adaptation to actually being able to travel to see someone, to have an open conversation, that kind of thing.
Okay, can you hear me now?
Yeah.
Okay. Hi, this is Amy Trowbridge. I'm a pediatric palliative care clinician, and I'll preface my comments with that because I don't take care of adults much. But I feel like I want to call out a bias that we have as palliative care clinicians, as people who are drawn to this work, that conducting a good goals of care conversation is a win for us, and that when families have an opportunity to do these kinds of things, we feel better about our job. It's why consultants consult us, because they want that for their patients and families. It's why we went into this work. And I think that there are times, and you brought up a few of them, where that can get dangerous, where our own drive, what we want so badly for our patients, can get in the way of really understanding what is most important to them. And it might not be a goals of care conversation. It might be focusing on living as long as possible in whatever state they're living in. And so I guess I just encourage us all to examine that and kind of hold these. There are many, many, many people who have benefited so greatly from our work in this area, and that also, if we push too hard, we can cause harm.
Thank you, Amy, for that perspective. I couldn't agree more, and I think it's really important that you brought that up. So thank you for that. There are certainly ways in which this work is not welcome or wanted, and sometimes we just need to be okay with that, and that's not easy.
And Lorraine, David has his hand up as well.
Okay.
Yes, thank you. I was just thinking about the dementia scenario where agency is disappearing, and how to navigate that tricky process while the person is still able to consider some of these issues. It might be worth special mention.
I think I agree with that. Here, what comes to my mind is the importance of the patient and the unit of loved ones surrounding them in navigating what the patient wants and the interpretation that can come from the loved ones who really understand a patient well. Those are things that come to my mind, and I'm sure there's a lot more in comments that other people may have as well about how this works with dementia and other cognitive issues as well. Yeah, thank you for bringing that up.
And I think, unfortunately, we're going to have to start wrapping up because we have reached 9 a.m. But I just want to thank everybody for their wonderful participation. I want to thank Reverend Dr. Lorraine Leist for inviting us into this special conversation and for all of her work in this area. And thank you, everyone. Lorraine, you can see some really lovely comments in the chat.
Okay, yeah, great. Thank you so much. I appreciate everyone being here and really participating in the conversation. Thank you, thank you, thank you.